Everybody in.
Hi, everyone. Welcome to another session of VMR. Today, I'm very excited because we're going to be discussing this case with Dr. Ravi. And how are you guys? I hope that everyone is having a good day and just ready to get a lot of learning.
Oh, thank you, Jimena. Thanks for co-discussing today. I just asked Jimena right on the spot if she wanted to co-discuss, and she jumped right into the fire, or out of the frying pan into the fire, I guess. But yeah, I'm excited to discuss this case. First time I'm getting to discuss with you, so this is always fun. So I really appreciate you jumping in to co-discuss. And we have a case presenter today from Emory, and I'm going to ask Jordan to unmute and introduce herself.
Hi, everyone. My name is Jordan Hildenbrand. I'm a resident PGY2 at Emory in the combined internal medicine and psychiatry department. And I like Patrick Mahomes, unlike some other people on the call.
Yeah, so I guess one of your fun hobbies is probably Kansas City Chiefs, and who can deny the just amazing talent that he is. So amazing job this year with the going against all these amazing teams, and he just knocked them down one by one. So anything else you like to do in Atlanta, Jordan?
Oh, well, in Atlanta, there's a ton to do in Atlanta. There's a lot of good hiking when you go into like North Georgia. I have 2 cats, which is probably the most important thing about me. There's a lot of good food and a lot of different cuisines. So yeah.
Awesome, awesome, great to know that. And how old are your cats, and what are the names?
They're like 5-ish. Eden and Esther are their names. They're cute.
All right, we'll start with the first aliquot, and Jimena, I'll let you tackle the first part.
Thanks, Dr. Ravi.
Okay, so do I give this information? Okay. So the chief complaint, this is for the initial one-liner, this is a 33-year-old male, and he is presenting with like fatigue and weakness. His chief complaint was, I was getting short of breath washing grapes, so I came to the emergency department.
Dr. Ravi, do you want Dr. Hildebrand to give us more information, or do you think that we can start with this?
I think we can start with this. What do you think?
Well, I think that first of all, it just catches my attention, the fact that we're dealing with a very young person. He's 33 years old. And I think that this should like raise up our alarms when it comes to shortness of breath, because usually when we have somebody that's younger, um, our usual causes of shortness of breath can change. I would be very interested to know like what is this person's baseline and if this person has other comorbidities, because if this is his baseline, then I guess that we can not treat this as an emergency. But another thing that I would be interested to know is the time course, like how long has he been with shortness of breath? Because if it's super acute, then we would worry about causes like PE and MI in a young person. Whether if this goes for a long time, maybe we can think about other more chronic causes like anemia or an infection. But I'm curious to know, what are your thoughts on this, Dr. Ravi?
Oh, I just want to highlight the sort of breakdown that you've done right now, your approach, which is early on in the process to gather key data, and also hypothesis directed questioning. Now you have a couple of thoughts there, maybe, like you mentioned, but you're not ready to commit to a diagnosis or to a particular pathology. So you want to gather key data regarding baseline, how this has impacted the patient, and also identifying this is a young person. So the typical pathologies don't apply to somebody who's young. So they may have a very atypical presentation of something that you may see. So I would, like you mentioned, the time course and a lot of this fatigue and weakness, we've been seeing a lot of it in the last few weeks, I noticed. But they're not conditions to themselves. They're more related to something that's underlying. And the key is to try and expose or unmask that underlying process. So key here would be gathering maybe some epidemiological data in the history, also exam and labs. Also to implement high value care, meaning don't do exhaustive testing, but do key testing that will support your hypothesis at this point and move the needle forward in trying to get to the diagnosis or get to that threshold for the diagnosis, at which time you can implement therapy. So there's many things. The list is exhaustive that can cause fatigue, weakness, shortness of breath. But I think a key highlight that you did share with us was this is a young person, so we have to be really careful in trying to determine what's going on with the patient. So back to you, Jordan, for the next aliquot.
Yeah, so I heard a lot of like questions about like time course, functional baselines. I can give you some of that information. This is really more like a subacute to chronic presentation. This patient presented to me in November, and he said he started feeling like, quote, less himself around July. So that's like at least like 4 or 5 months. And he first noticed feeling less himself after like an episode of near syncope, when he was like just going on a leisurely walk with his wife. And since then, he feels like he's had like this. And I saw someone ask about like, is there focality to the weakness? It's more global, like just gradually like decreased exercise tolerance. But he was like attributing this to some like lifestyle changes he had made, so hadn't really thought anything of it. But the grape situation is what kind of like raised his alarms to like, maybe this isn't normal. And in the last 1.5 to 2 weeks specifically, he feels like it's almost like a subacute worsening of this chronic weakness, where he feels like much more fatigued and lower energy. He drives a truck for a living, and he'd get tired just like driving the truck.
I guess we can pause there. I'll start with a few points, Jimena, and then I'll turn it over to you. But what is concerning driving a truck, what you really have to be cautious about are conditions that can lead to a motor vehicle fatality or accident. So various things that you need to diagnose in somebody who operates with a CDL license is sleep apnea, obesity, hyperventilation, any sort of cardiac condition, things of that nature that could end up causing a motor vehicle accident or fatality. And this syncope that was kind of mentioned, there was these syncopal episodes. That is very alarming and something I would be very concerned about, especially if the person is working and operating a truck on a long distance route. So approaching just sort of laying down a framework to syncope, you have to start thinking about maybe things that could be pseudo syncope or cause syncopal like episodes. So things that could mimic a syncopal episode. You could have seizures that could mimic a syncopal episode, hypoglycemia, TIA or vertebrobasilar TIA could essentially cause something like a syncopal episode. Then you get into the buckets of syncope. So there could be things like we usually have like 3 buckets. You could have cardiac associated syncope, reflex mediated syncope, or orthostatic hypotension. And then just doing a simple right off the bat orthostatic maneuver could help disclose if there is something like autonomic dysfunction or maybe a volume issue. But we don't have anything in the history or the stem of the history to purvey that this patient has maybe a volume issue or maybe anemia to cause like an orthostatic condition. He's young to have autonomic dysfunction unless there's an underlying neurological process, especially something that's early onset. So that's also something to think about. And people would mention something about the heart, maybe also looking at the brain as well. So we're not sure if the syncope is related to either these organs, or is it due to feeling fatigue? Sometimes people are fatigued and they just feel like they're going to pass out. So that's also something to consider. But what's going through your mind, Hamina?
Well, thanks for all that beautiful breakdown, Dr. Ravi. I think that when I see a transition loss of conscious, I immediately go to your scheme of the 6 S's, which is basically what you just told us, but in a more beautiful way, I would say. So that's definitely a consideration. I think that the fact that we have shortness of breath and we have syncope is kind of guiding us to this cause being cardiac potentially, because now we're having like 2 symptoms that are like very often from a cardiac nature that are kind of like merging or happening at the same time. So when I do the cardiac evaluation, this patient, I would be very, very careful and very, very meticulous. I also think that we can also consider other infections that are going to be a little bit not that acute, like for example, myocarditis. I would be curious if this patient has had like any other infection, because that's something that could be potentially at play. I don't think I have anything else to add because you pretty much covered it all. But I would be very curious to know if yeah, like a little bit more about the behavior of this patient to just kind of like understand where do we stand and which are the organs involved.
Yeah, I mean, just while you were going through your thoughts there, I think it helped me trigger something. I was like trying to be sort of expansive in my thoughts, but you know what? If we just kind of boil it down, use system one thinking, truck driver, long routes, syncope, what comes to mind? Anything come to mind? Sitting for a long time.
Like we can have like a thrombotic event, a DVT,
Exactly.
PE. Yeah, that those are the things that we talk in at the beginning that would be like very concerning and that are life threatening and that can present at any age.
So I
And
think,
yeah, it's a matter
sorry.
of just like diagnosing it, and then we can just pause and understand like why is this patient having it? But the important thing is just to diagnose it and treat it.
Excellent, excellent. So we kind of get caught up, yes, as a young person, and we have to start thinking about bad genes and all of those. I forgot all the sayings, but bad luck, bad genes. Somebody remembers bad luck, yeah, and bad behaviors, risky behavior, yeah. If none of those apply, maybe with the bad genes, there's a prothrombotic disorder. So we have to be careful we don't we don't deny base, or we do what we call that bias base rate neglect. We neglect things like PE, and we try and go for autoimmune disorders, more esoteric things here. But yeah, I think it'd be imperative to maybe rule that out, and then that gives us time, because this could be a PE could be very dangerous in a patient like this, and if we rule it out, it buys us some time to consider other diagnoses. Another thing I would think about, we haven't gone to the past history, but medications. Are there certain medications that could also be causing this patient's condition here? But I'll flip it back to Jordan for the next aliquot.
Okay. And then I'll just give you like a quick review of systems and then can give you his past medical history. So he denied no fevers, no chills, like no infectious or B symptoms. He denied sick contacts, but does have a school-age child that lives in the home with him. No cough, no runny nose, no headache, no vision changes, no like blood loss from anywhere that he could identify. No nausea, vomiting, diarrhea. We already talked about like the shortness of breath. He endorsed intermittent dizziness and like possible weight loss, as well as like purulent eye drainage. And then he also like he was really fixated on having like recent hearing changes that were kind of over the last few months, like sounds being less crisp. But he denied pain anywhere, no chest pain, no extremity or MSK pain either. And then he also reported he had some like recent dietary changes where he had like stopped eating meat for like a month, but had since resumed eating meat and was like trying out intermittent fasting. But in terms of his medical history, he has hemoglobin SS, and that is it.
All right, very interesting. I'm gonna have Jimena take the lead with the new data.
Well, I think that from all the information, so I just want to clarify something. He denied the weight loss, right? He didn't have.
He subjective weight loss. He was new to our health system, so I don't know what his prior like weight was.
Okay, so I think that every time that we have weight loss is just such an unspecific or non-specific symptom, but it raises concerns of something more chronic, something inflammatory at play. So I always take seriously when we have weight loss in a patient. And I think that also the past medical history of this patient having an S trait in his hemoglobin then just opens this new possibility of like all of well just having chronic anemia and just wondering if this anemia is causing the symptoms that we've seen here. And then it just also guide us to having like other potential um like causes of these types of patients, you know, like when we have acute chest syndrome, and then it would be like it wouldn't be surprising the fact that it can have like a veno-occlusive crisis, that we can have a thrombi. So the hypothesis that we were looking at a few aliquots before, this person being a truck driver and just being sitting down a long time with this kind of like raises even more that possibility, and we definitely need to look into it.
Wonderful breakdown, Jimena. I just love that you extracted the significance from this, which is now the introduction of the SS trait or the sickle cell trait, and now relating it as a pivot point to possibly what's causing this patient's condition. And you can't deny the fact that hemoglobin SS has a large amount of different complications which can present in many ways and can cause fatigue, weakness, and so on, because you have the anemia. So anemia, probably the most common manifestation of this, but then you have a set of very nefarious complications which can be devastating. So you opened up the book on the complications with having, yes, the pulmonary related issues, the pulmonary hypertension, acute chest syndrome can be devastating. There's then infection you had mentioned a while back, because you are in somewhat of a immunocompromised state. Then tissue infarction can also happen. Splenic crisis or sequestration can happen. Asplenia eventually, but at this age you would anticipate the spleen not being functional. Then you also have to worry about other things like we were talking about the CNS, like stroke could also be a sequela of sickle cell disease, not to mention painful crisis, but we don't have that sort of in the HPI, we don't have this like generalized pain and like pain that's like 10 out of 10 and excruciating. So I doubt this is a crisis at this point. I remember Hans telling us about a patient with priapism a little while back. That was a fantastic case. So that can also be a manifestation of this. And then sickle associated nephropathy, ocular disorders, arteriopathy as well. So leg ulcers as well can happen. So, and then the thrombotic states and sort of the hyperviscosity states that you can get with this too. And also bone marrow conditions like aplastic anemia from B12 infection. So right now, I think that is a major point which we can pivot on, but I'm not sure which of these conditions could be causing this patient's presenting complaints here. But I'm worried about the brain. I'm worried about the pulmonary vascular system, and then also the hematological system here. And the purulent ocular drainage, I'm not sure. What could this be opening the door on? Multi-system disease mainly. People had mentioned in the chat something about maybe autoimmune conditions. Could this be part of an autoimmune phenomena? I'm not quite sure. I'm not going to heavily invest a lot of my cognitive energy at this point. But I'm not seeing the symmetric sort of joint involvement or axial spine involvement or any skin abnormalities or things of that nature that would turn me towards maybe a multi-system inflammatory disorder. But at this point, I think let's sort of entertain the hematological condition or the system and sickle cell disease and see what else do we have in the next aliquot. Anything? Go
I
ahead.
totally agree with you, Dr. Ravi. I think that when we have well, just the port on eye drain does not tell us a lot, because when we're talking about immunological diseases, we need to like actually define like if it's a scleritis, if it's a uveitis, if it's just a regular conjunctivitis that could be at play. So I think that you're very wise in just not investing a lot of time there yet. And I just want to remind you guys, because you know that I'm an ID enthusiast, that the fact that this patient has the S trait is opening a door to having another atypical bugs causing infection, and I would be particularly worried about salmonella. I think that we don't have like a good case yet of this patient having endocarditis, for example. But if that were the case, like I would be worrying about those atypical bugs that could have like a subacute presentation. Yeah, and thanks for all of the great information that you gave us, Dr. Ravi.
Oh,
I
thank
think
you. And great breakdown of the eyes and the different kind of inflammatory conditions of the surface layers. So back to you, Jordan, for the next article.
All right. Just for a little background on his baseline and the setting of his sickle cell disease, his baseline hemoglobin runs between like 7 and 9. That was previously known. He has pain crises usually about once every 2 to 3 years. And they typically consist of like low back and leg pain. He's not on any home opiates. He's actually not on any home prescribed medications at all, including hydroxyurea. He's not on hydroxyurea. Family history is non-contributory, other than like one of his parents had hemoglobin SS as well. In terms of social history, it's pretty much as we've already talked about. Works as a long distance truck driver, lives with his wife and his 10-year-old child. Health related behaviors, he's pretty recent. He doesn't have like a primary care doctor or a hematologist. He's fairly new to the area, so he hasn't like established with our health system before. And then allergies like aren't very exciting. He hasn't been in contact with anything that he's allergic to recently, and it's nothing we like commonly give.
We go into the exam and then I'll have him take that aliquot.
Vital signs, his blood pressure laying in bed was 123/58. Heart rate was 80. He's afebrile. Respiratory rate 16, satting 100% on room air. On exam, he's like laying pretty comfortably in bed, but is really thin appearing, but non-toxic. His pupils are reactive to light. His extraocular movements are intact, but he does have like pale conjunctiva and pale mucous membranes, like really pale. And his oral mucosa is dry, but no pharyngeal erythema, no like postnasal drip or anything like that. No lymphadenopathy on his neck exam. His pulmonary exam, his lungs are clear. His breathing is unlabored when he's at rest. He does not currently have an O2 requirement at rest. No crackles or anything. Cardiovascular exam, regular rate and rhythm, no murmurs. Normal S1, S2, no rubs or anything. No like JVD, no peripheral edema. GI, his non-tender abdomen, not distended, but he does have a palpable spleen tip. GU, he had no suprapubic tenderness. It was otherwise deferred with a plan to complete a DRE if indicated. Once he was in a hallway bed, so we weren't going to do that there. But his MSK exam, he had normal range of motion and grossly normal strength when he wasn't limited by like just like this like generalized fatigue. His skin was warm and dry, but pale. He had delayed cap refill, and he had no focal deficits on neuro exam, was fully oriented.
Thank you, Dr. Hildebrand, for that information. I guess I would like to start to just like looking at the saturation. You know, we have a patient with shortness of breath, and now we have a patient who's saturating 100% room air. So that just kind of tells us that probably the problem is not in the lung tissue per se. So that just kind of leaves us a little bit more, that's a little bit more reassuring for me that we're not dealing with an emergency. I guess that with the pale conjunctiva, like we're expecting that because this patient is has a chronic anemia, so I wouldn't give a lot of attention to that because anyway, we're definitely going to get a CVC and we're definitely going to evaluate the hemoglobin. I'm glad that the cardiac evaluation is also a little bit reassuring. You know, we don't have a JVD, and one of the concerns that we would have with this patient is having pulmonary hypertension. So right now, that's just a little bit more reassuring. Of course, we can have just a pulmonary hypertension that it's not that bad for us to see it on the physical exam. And this patient's definitely, I would like an echo. So like I'm good right now with that. And then I am really surprised about the suprapubic tenderness. I think that this opens up asking the patient a little bit more about UTI symptoms. You know, that would be kind of infrequent in a man. If that's the case, then it just opens up another realm to having like sexually transmitted diseases, evaluating for HIV, and I think that an insidious infection can also trigger, you know, a crisis for this patient. So that would be also important to evaluate. And I'm curious to know what you think about all this, Dr. Ravi.
A remarkable extraction of important points from the history. I think, yeah, look, starting with the vital signs, I just love that you went through that. Not particularly remarkable. The patient is exhibiting stability. And with, I kind of would be interested in the heart rate if the patient was massively anemic. I would look for at least tachycardia, but this patient has chronic anemia, so they are somewhat used to compensating to a particular point. But if this was something like a crisis, I think the heart rate would be really high because of pain, because of anemia, and so on, dehydration as well. And the patient is immunocompromised, you would say, with sickle cell disease. And without a fever particularly won't rule out an infection. So we do have to be mindful of this and not completely close the door on infectious contributions to this patient's presenting complaints. And then going through the suprapubic tenderness, I think you raised a valid point that this could be something genitourinary, and there was no masses there, so maybe no malignancy, no palpable bladder. I know one really difficult thing with long distance truck driving is inability to stop for to use the restroom. So truck drivers will be used to driving long distances to then get to a restroom. So urinary retention could be, especially in the young age, not something you would see, but you would wonder about. Anything else? I think I guess if there was flank pain, you could think about the kidneys. One other thing I kind of wanted to shift to was this spleen. Now we kind of talked about young with sickle cell disease, you tend to have issues with, with the spleen eventually becoming atrophic down the line. But with this patient, we're getting a large spleen, and what does that clue us into? So one thing I would be very worried about would be splenic crisis, and that usually is just where you get a major thrombosis within the spleen and then enlargement. And the spleen can usually trap a lot of red blood cells. So you get sequestration of platelets, you get sequestration of red blood cells. And I think this is a particularly painful condition, which we're not sort of getting the sense here. The patient's having a large palpable spleen. So I would sort of look for abnormalities in the CBC in regards to this large spleen, and then take it from there. But like you mentioned, the patient has signs of anemia. The exam, Jordan, you did a wonderful exam there looking for signs of anemia. So there is conjunctival pallor. The mucosal membrane is dry. I think that was also, you can see pallor in that area as well. And being thin, I like this word non-toxic too. I kind of tend to use that too. Does this patient look sick to me, and do I need to urgently go through what do we call it, alarm conditions? Sick, not being toxic also means to me the patient is septic and we're not getting that flavor. But I'm interested in imaging, getting the hematological studies, and then taking it from there. And let's see. Anything else, Amanda, before we go to the next aliquot?
I guess that sometimes with the physical exam, I think of like the positive signs, but then I also need to think about what's negative of what I was thinking, like it's as the positive signs are as valuable as the negative signs. And I think that in this case, if we were thinking about something more chronic, the fact that the patient does have lymphadenopathy, for example, like that just is reassuring that maybe his process is not as chronic as we thought it would be. So that's just kind of like a point for me to reflect on, that it's not just the positive, but also the things that we didn't find.
That actually, while you were talking, you kind of reminded me of a condition that I did see in a patient with sickle cell disease, and a very unfortunate, very dangerous condition called sickleus hepaticus. That's kind of a fancy term for this hepatic injury from massive sickling, and you have acute liver failure in that case, and that can be very devastating. We're not kind of getting that condition here. It's something that would, like, somebody would be admitted with a crisis and would eventually throughout the day and night have elevations in their liver enzymes, and then would have jaundice and so on. But we're not getting that kind of a flavor here. We don't have jaundice at this point, but this is a condition that could actually evolve over time. So I'd like to see what Jordan has in store for us with the labs.
Yeah, so, oh, and then just since you were talking about vitals, this patient does have a history of acute chest in childhood. So I think that's just like another note of like, he's not afebrile, he's not hypoxic. His like lung exam is pretty benign. So like things that we were encouraged by on the exam. But anyway, for labs, his white count is 5.6, his hemoglobin is 2.9. From a baseline of like 8 to 9. His AST was mildly elevated at 58. His creatinine was normal at 0.8. His LDH was 681, which is high. But his lactate was normal at 1. His haptoglobin was less than 30, which is low. His iron studies were consistent with anemia of chronic disease. We did get a BNP that was 140. His trope was normal. And then for his like sickle labs, his retic percent was 10.4, which is high. He had a very high chloride of 122. And he had a negative anion gap at -10. And he also had a mildly elevated total bilirubin at 2.5. His coags were fine. His UA was unremarkable. And he had blood cultures ×2 that had no growth. We had a chest x-ray that showed bibasilar infiltrates, but more concerning for scarring than an acute process. And his EKG was sinus rhythm. His labs were wild.
Yeah, I see that, Jordan. By the way, Jordan, absolutely wonderful presentation. You just flawlessly just presenting all the points so well and very effectively. So I appreciate you for organizing and putting this case together for us today. making it easier for us to go through the data points.
And I have the
But
labs kind of like in tiers, but I'm gonna like pause here, let y'all
okay,
talk about this, and then I'll give you some more info.
awesome, awesome. So I'll sort of kickstart things off. I mean, obviously we were anticipating there's going to be anemia, right? But this anemia is much more severe here. So when you have crisis, of course, you're going to have a lot of sickling, and you're going to end up having pain in major areas, which could be the joints or the lung or other areas. If you have CNS sickling in the CNS system, you'll have a major stroke, and we're not seeing any focal neurological deficits or seizures or anything of that nature. The chest and lungs, like you had mentioned earlier, the patient's not hypoxemic, is not complaining of chest pain, but there is some shortness of breath. And obviously, the shortness of breath, when you go through some of us like to use this shortness, what do you call it, dyspnea pyramid, and you can find that on the CP Solvers webpage. You can see at the top there's bad blood or no blood, and here we're dealing with no blood or lack of blood here. So the shortness of breath is attributed to this. But we're seeing all, as somebody had mentioned, Brian had mentioned, we're seeing all this signature of hemolytic disease. The LDH is elevated, although haptoglobin is not low. Oh, actually, it is low. Sorry. So haptoglobin is low. We have sickle cell anemia. When we go through hemolytic anemia, the retic count will be high, so the bone marrow is trying to compensate. Then the next step is going through the labs, which we see here. The LDH is high, haptoglobin is low, Billy, indirect Billy is high, AST will be high. And then the first order of business is to do a Coombs test. The Coombs test will tell us if there is an autoimmune hemolytic anemia, mainly warm, cold. Warm is good, so IgG related. Cold would be IgM. And if the Coombs is not positive in this case, then we have to think about MAHA. So here we don't have the platelets here, but if we do have coexisting thrombocytopenia, coag abnormalities, this could be a microangiopathic hemolytic anemia or DIC if there's low fibrinogen and abnormal PT, PTT-INR. And then also in the hemolytic world, we also have to think about the RBC itself. So we already have a hemoglobinopathy here, sickle cell disease. You can have thalassemia and so on. You also have to look at the membrane as well. So membranous abnormalities of the RBC, which could be something like spherocyte disease, elliptocytosis, and so on. And then your favorite world of infectious disease, what could be in the RBC as well. So you can have malaria, babesiosis, leishmaniasis, and other various diseases causing hemolytic anemias. And then drugs. We don't have any drugs here, but notorious one, which could cause like a G6PD deficiency. So sulfonylureas could trigger something like that as well. So here, I think it's the only thing that I can really see is a sickle cell disease that is causing this fingerprint of hemolytic anemia. But this chemistry, I'm going to have you take a stab at it if this kind of clues you into something. It's kind of interesting.
I don't think that right now this is cluing me into something very specific. And first of all, I want to say thank you for that master class that you just gave us on the management and the causes of anemia. I guess that the only thing that it's in my mind is I remember Ravi discussing another case, and he was just saying this question, like, is this anemia enough to explain all of the symptoms in this patient? So I guess that at the beginning I would say yes, because it is very low. However, I would be very careful to evaluate the patient after we've resolved this, and because we need to give this patient transfusions, and it's like that's the first thing that we need to do. And if after that we just keep seeing that the symptoms are still there, then just wondering like what else could we have missed, because I am actually very surprised to know that his hemoglobin is basically 3 and he's he's living. He's living his daily life, of course, you know, with limitations, but I guess I would expect the patient to be worse with this hemoglobin.
Yeah, it's kind of like I'm kind of glad you framed it in this question. That's a absolutely like remarkable question there. Can you explain this, the degree of symptoms by this anemia? And patient coming in with sickle cell disease, I would worry. I'm not getting that sense of like there's a crisis going on. It's sort of the patient is just having shortness of breath and the syncope, which can be attributed to anemia, but sickle cell disease, the patients that I've had from experience, they've had just devastating pain, and the patient's not on chronic pain medications. So there's another process that we haven't yet unmasked that could explain these findings. The low anion gap is interesting because of the high chloride. I think that's when you calculate the anion gap. The anion gap will be with the extensive chloride or negative charge, you have the anion gap will be low. But when Jordan mentioned low anion gap, negative anion gap, a couple of things come to mind. You can get low anion gap in autoimmune disease. You can get it in multiple myeloma. There are a couple other conditions I'm forgetting, but I know Robbie has a scheme on low anion gap. Bromide toxicity, I think, is another one, if I remember. But I have seen it in multiple myeloma in autoimmune disease as well. So something to think about. But we do have the reason for this, which is the high chloride. And now, why would this patient get a high chloride? The most common usual reasons would be infusion of normal saline. When a patient with sickle cell disease presents, a lot of times we're told to give a large amount of intravenous fluids. Normal saline is given sometimes. Normal saline, it kind of helps because with the mechanism of sickle cell disease, you want to at least have the cells further apart, and by hydrating, you will move those cells apart, because one cell that starts to sickle will actually cause a chain reaction and cause further sickling down the line, sort of like a domino effect. So giving intravenous fluids, normal saline usually is not the fluid of choice. Giving normal saline may actually cause dehydration of the RBCs. You'll have extracellular hyperosmolarity if the sodium chloride goes up, and then that will actually cause worsening of sickle cell in a patient with this condition. So we tend to go to a lower tonicity fluid, maybe half normal saline may be recommended in that case. So hyperchloremia can be sometimes iatrogenic. So I'm kind of wondering about that. The X-ray by basilar infiltrates, I'm not sure if this is significant. Is this a signal for heart failure? Is this a signal for bibasilar alactasis? Not quite sure, but I think Jordan has a few more aliquots, which might help us along this way. Back to you, Jordan.
Yeah, sorry, I was just answering the ferritin question. It was like mildly elevated at 382.1. But yeah, so I have some additional info for you. So just where our clinical team's head kind of was at this point, we were like, okay, this guy has a profound anemia, much worse than baseline, but doesn't appear to be in a sickle cell crisis, and no pain. His labs aren't particularly concerning for like an acute like sickling crisis, though he certainly has evidence of, we know he has sickle cell anemia. So we were like, what else can cause an anemia in a human? And so we like tested for HIV, that was negative. We did a hepatitis panel, it was all negative. We tested for flu, COVID, RSV, all negative. His procalcitonin was normal. RPR was negative. We tested for parvovirus, that was negative. And he did have a high EPO that was 324. We got an abdominal ultrasound initially to assess the spleen, but then the tech like just didn't do it, but his liver was fine. And but we also got a TSH, which was 120. And so then we were like, is the TSH artificially high because this guy has like a single red blood cell and the lab's not right? And so we repeated it and his TSH was 124. So now we had that, and then we sent further thyroid studies, and he had a low free T4 at 0.32 and his T3 was 24.9. And so, yeah, that's the labs we did next. And then
Aha.
we did a little more history, and he told us he was taking some supplements, and the most notable one was one called Dioscovite, and we Googled it. It's on a website that says it was developed by an MD, but is not FDA approved. And it was a supplement called Dioscovite and one called Arnica.
Very interesting. We didn't really explore the domain of supplements and alternative medication, but that actually has relevance in almost every case that we have in CP solvers and actually in real life. So, question, Jordan, he drives long routes. Does he drive south of the border?
Not that he told us.
Okay. Some of these supplements may be obtained abroad and haven't been fully vetted by the FDA and other societies. So these meds or these supplements I'm not too sure about. We may just have to Google to see the side effects. But what do you think now, this thyroid panel? And thyroid panel actually has relevance in working up anemia, like Jordan mentioned. This is not a sickle cell crisis. We kind of were anchoring on sickle cell disease. That's just the baseline. On top of that, like Jimena mentioned, there's something else that's attributing the anemia in this patient. And what is that? I guess doing a thyroid panel is always important in this case because that can actually affect any organ system. And what do you think of the thyroid panel, Jimena?
Well, I gotta be really honest right now, and I think that I don't have the experience yet. I struggle with knowing when to get a thyroid panel when you have an inpatient situation. I think that that's still hard for me. I guess I would like your help and how would you interpret this? I do recognize that this patient is not like acutely sick as to make me think that the thyroid panel is not accurate, but I would like your thoughts on it and how do you tackle that?
Absolutely, yeah. I appreciate you. Yeah, it's kind of a difficult thing. Like, okay, you have this thyroid panel, but how should we approach it? And I usually will take a look at the first test that they always mention in any textbook would be the TSH. So looking at the TSH here, it's remarkably it was deleted, but I think it was elevated, right? It's remarkably elevated.
Yes,
Jordan?
Dr. Ravi,
Okay.
they just moved it a little bit up.
Okay. Oh, there it is. Okay. So with the TSH being really elevated, you have to start wondering, okay, the thyroid is getting a signal from the pituitary, and the feedback mechanism, usually if the thyroid is like shut down and is not making thyroid T3, T4, then the pituitary will be like, okay, I'm going to try and wake up the thyroid and send lots and lots of signal, which is TSH, to further knock on the door and like, hey, wake up, make more thyroid hormone. So we have a state of primary hypothyroidism in this case. So the thyroid is just not making enough signal, and the feedback mechanism to shut down TSH is not there. And so in this case, like hypothyroidism, what autoimmune condition can cause primary hyperthyroidism? Hashimoto's disease. And I'm just wondering, Hashimoto disease, and we talked about autoimmune conditions, can also cause a negative anion gap. So just an association. I don't know if it's the right association, but just something to dwell on. And when you have hypothyroidism, you get a large number of different complaints, like the shortness of breath. I'm really tired. I'm very weak. People have mentioned asthenia. Now we go back to the weakness that we had in the first aliquot. So this could also be a reason why this patient has anemia due to thyroid disease. But then the question is, why is this patient having a state of hypothyroidism? We do then have to go through doing all the different testing in this case. Other sort of mimickers of primary hypothyroidism, you can have a subclinical hypothyroidism, which we don't have here, where the TSH is elevated and the T4 would be normal. And then you could also have probably maybe a central hypopituitarism as well. So the TSH is low and the T4 is low in this case. But here we have the opposite, with the TSH is high and the free T4 is low. And this therefore is a case of primary hypothyroidism. And then we have to go through the causes, which could be Hashimoto's disease. If the patient's had in the surgical history, we don't have resection of the thyroid. What if this patient got any radiation or radioactive iodine in the past? In this case, then we also have to entertain medication-induced hypothyroidism. And again, these meds I'm not sure about, but what are common medications that could cause it? I know lithium could be one that could cause it. Interestingly, talking when discussing this case, and Jordan may have seen it because we do have patients that are on lithium. You may have seen this before, but this can cause hypothyroidism. Amiodarone, amiodarone can cause hypo and hyperthyroidism. So something to look at. You may see it in the wards or in the clinic, in cardiology clinic, because we have a large number of patients on amiodarone for atrial fibrillation. So those are a few things that come to mind. Any questions, Jimena? Does this clarify these labs?
Yes. Thank you, Dr. Ravi. I think that is very valuable, the approach, especially in the inpatient setting. I guess that just thinking about hypothyroidism, I think that we only missed asking about the patient of his iron intake. That's another thing that could cause hypothyroidism. And we also need to entertain the possibility of a cancer if we're thinking about that. And then heavy metals, like those are the only other things that I would be curious to evaluate. I really don't think that this is cancer. I would focus more on what you said about just Hashimoto, evaluating the intake, and then kind of testing for heavy metals, because he's a truck driver and he may have exposure on the road. Those are my thoughts of what we talked about right now.
Thank you, Jimena. Yeah, what also is interesting, I'm trying to go through all the different the associations or the typical presentation of hypothyroidism, which is being cold, bradycardic. You do have the asthenia and so on, cold intolerance, which we're not kind of seeing here. So I'm questioning myself. I just love to borrow that questioning of the findings that we have here. Is this really a true presentation of primary hypothyroidism, or is there something else that's sort of bubbling under the surface here? So I'm going to turn it back over to Jordan to give us the next aliquot.
Yeah, this is so fun. I love this case. So additional info, we were like, why is this guy have such bad hypothyroidism? So we got a thyroglobulin antibody that was negative. We got a thyroid peroxidase antibody. It was collected and weirdly never resulted. I don't know what happened there. But what we actually ended up doing with these supplements on the internet, we learned that the active ingredient of deoscovite is thiocyanate. And so we actually consulted toxicology given that. And so we tested for cyanide in the blood, which was negative, but then we also tested for thiocyanate in the serum. That was and its level was 154. And the normal range is between 3 and 12. So he, like, upper limit of normal is 12, and he was 155 for thiocyanate in the serum. Also, this is a supplement he had been taking for almost 5 years. And so I don't know if you want me to, I can kind of like explain that more, but I don't know what you guys want at this point. But so basically what the tox people said is that the thiocyanate, it's like SCN minus. And so that is what was causing a pseudo hypochloremia. So whoever put that in the chat, like, awesome. And that's what was causing that like pseudo negative anion gap. And it's actually displacing the iodine from the thyroid and causing this like profound hypothyroidism. And so our thought was that that was causing like the severity of the anemia in the absence of a pain crisis. And and like there's only like one, there's not a lot of documented cases related to this, but actually I just did some chart checking, and like 3 months after his presentation, he had stopped the supplement and had actually been out of his thyroid medication for a couple weeks, and his TSH and free T4 had normalized.
Wow, that's just so remarkable. I'm just sort of gobsmacked. We were going through this case, and I just had no idea thyroid will be involved, and then a supplement that he's just taking for 5 years and not really knowing the consequences of this, causing profound anemia. And again, Jordan just so remarkably presented, and so just eloquently the aliquots just compartmentalized and delivered. I just really appreciate you spending the time and bringing this case to us. And it just shows how important it is. And sometimes we do look over asking the question, are you taking supplements, any supplements that you may be taking? So especially anybody that may be coming from abroad and bringing supplements that may be herbal remedies and other things like that. It's very important to definitely look through and fully vet those supplements. And that now makes sense why the anion gap was in this negative mode, and just the I have to go over the pathophysiology of this causing the low anion gap, and then also the hypothyroidism. So again, this is very educational, and I definitely learned a lot from you, Jordan, and I again appreciate you very much for bringing this case. Jimena, any reflections?
Well, I am super impressed. I think that what you said is just very true. And I think that kudos to your team, Dr. Hildebrand, for just going to the extra mile and actually like investigating what are the supplements and just taking care of this patient, because I don't think that a lot of people would have caught this kind of intoxication. And thanks for bringing the case. This is very educational. You know, when I thought about hypothyroidism and like metal intoxication, like I would just only have like iron if it's like hemochromatosis, and then probably like cobalt. But this is just adding more and to that differential diagnosis. As Dr. Ravi said, this was masterfully presented, and this also shows that we should not anchor. You know, just because a patient has like this certain type of condition does not exclude the patient from having like other regular conditions. They both can coexist in the same universe. So thank you so much for that. I really enjoyed discussing this case with you, Dr. Ravi. Thanks for all the learning.
Oh, same here. Yeah, and Amina, you're right on the money with that bacterial conjunctivitis. Like that's a red herring. Do not go down that rabbit hole. We were thinking episcleritis, maybe GPA, one of these conditions. But kudos to you for really going to bat with this case and looking through all the data and figuring out, yeah, this is likely a hematological problem, sickle cell disease, and then something else. Asking that question, can this be explained by sickle cell disease, or this anemia can be? So awesome question that really helped focus my thinking onto that question and sifting through the data really importantly. And amazing chat, bringing in, I think Dr. Braki brought in about this, the effects on the low anion gap and chloride. So thank you, everyone. Teaching points, Ashutosh, take it away.
Thanks, Dr. Hildenbrand, for bringing this case to us and all the amazing learning. Thanks for all the amazing comments in the chat. Thanks, Dr. Ravi. Thanks, Jimena. So I have collected a couple of teaching points while we were discussing the case. Like we always talk about in CPS, whenever we have a young patient, we need to think about bad luck, bad genes, and bad behavior. In this case, I think it could be said that it was a bad behavior, but intended, but not intentional. I think it was intended to be a good one, but turned out to be a bad. So whenever we see a young patient and the complaint is dyspnea, the differential diagnosis can be different. Timing and associated symptoms can give us a clue. Hyperacute onset would suggest something like pulmonary embolism or even myocardial infarction, even in young age. and generalized fatigue and weakness may suggest something underlying like infection or some autoimmune condition. Our patient had a profession of truck driving, and like sleep apnea and OHS, obesity hyperventilation syndrome, is a common cause of generalized fatigue in people with that profession. Syncope, whenever we have a syncope, we should always think of whether it is a true syncope or not. So pseudosyncope can be caused by something like hypoglycemia, seizure, and TIA, whereas syncope can be cardiac in cause, or it can be reflux or orthostatic syncope. Cardiac exam would be very important at this point, given the history of shortness of breath, fatigue, and syncope. And also, we should be mindful that given his profession, we should always think about BVD and its complication like pulmonary embolism, which can lead to shortness of breath as well. So our patient had a sickle cell anemia as well. So there are a couple of conditions which can cause shortness of breath through various mechanisms in that patient population. Anemia being one of them, acute chest syndrome, certain bone marrow pathologies resulting as a complication, hyperviscosity, and pulmonary infarct being some of them. And Jimena mentioned about like how HBSS is linked with salmonella infection, and we should also be mindful of that, whether in some way or form, whether that is causing, that is the result, like that is actually causing the patient's symptom or not. Whenever we think of suprapubic tenderness, urinary retention is probably the common one, and also given the profession of truck driving, it could be the case. It can also result from UTIs or bladder pathologies, like other bladder pathologies. And our patient had splenomegaly, and especially given the fact that it was HBSS straight, sequestration crisis should be in our minds. Given the fact that there was no tachycardia, we were thinking that it could be the probability of vaso-occlusive crisis or severe acute anemia being the cause would be less likely. Dr. Ravi taught us about sickle cell hepatopathy, which is basically like an acute liver failure caused due to vaso-occlusive crisis and causing the altered liver function test on the labs in the range of liver failure. And we also thought about like anemia in context of causing shortness of breath, but without hypoxemia, it can definitely cause like shortness of breath without hypoxemia. And our patient had low haptoglobin, high LDH, raised bilirubin, which suggested hemolysis. When we think of hemolysis, we are thinking in the realm of like autoimmune hemolytic anemia or microangiopathic hemolytic anemia, which can be differentiated by performing a Coombs test. There was a low anion gap as well, which can be seen in cases of multiple myeloma, high triglyceride and bromide. Like Dr. Ravi mentioned, we have a schema for that. I'll have to look that up as well to broaden my differential there. Our patient had really high chloride. As there's a history of sickle cell anemia, hydration and oxygenation is the key part of management. And sometimes like a lot of normal saline can result in these kind of lab. We also discussed about thyroid function test, especially in context of like inpatient. We discussed how low T3 and low T4 can signal the pituitary to release a lot of TSH, which can be very high. And we learned that like a very high TSH would suggest towards like primary hypothyroidism or mimickers rather than the non-thyroidal illness, which can cause high TSH, but probably may not cause this high TSH. And some other drugs and autoimmune condition can do that as well. So at the end, we learned that our patient was taking a supplement which contained a component which was hindering with the thyroid hormone synthesis and resulted in hypothyroidism. The component which was culprit of causing hypothyroidism is like thiocyanate, which inhibits the uptake of iodide during thyroid hormone synthesis and results in hypothyroidism. Thank you everyone for joining us. That's all I have.
Wow, Ashutosh, that's all you have? Thanks for those amazing teaching points. Thanks again to Dr. Hildebrand for bringing this case and Dr. Ravi for discussing it. We hope that all of you have a great day, and we'll see you tomorrow for another VMR.
Bye, everyone.